show you a case that taught me a lot. So this is a man that I essentially diagnosed with functional tremor. And what you see here, I hope the video continues playing, it's frozen on my end, but what you essentially have seen is that there is variability in the tremor when he does some activities. Doesn't seem to be disrupted, right? So I'm in general thinking that there is some unusual behaviors here. One thing I did not essentially prove is that there was any degree of entrainment. Interestingly, when I tried to examine his arms, you can see a lot more tremor. That's a very functional manifestation, right? So it's incongruent with most tremors. And so overall, my diagnosis was functional tremor. I think the only thing they did not document was entrainment, but all the other manifestations were consistent with that. The reason I'm pointing this man is because he went on to develop classic Parkinson's disease. And in fact, he went on eventually 9 years after that video to undergo deep brain stimulation. There were no other features. I think that the functional manifestations really disappeared, or what I thought was functional. There was a time I was thinking that I was entirely incorrect, and I called it pseudo-functional tremor. But in fact, what that did is that it made me think that sometimes we have diagnoses, and maybe sometimes we're right, but sometimes if we're right, we have to keep on thinking why everything else doesn't seem to go along with it. And I run into this particular manuscript essentially showing the experience of Cleveland Clinic colleagues in terms of the use of DAT scan. And I'm highlighting here that in the patients with psychogenic movement disorders, half of them were normal from DAT scan perspective, but half were not. So there are two conclusions from that. One is that they are really doing a poor job with their clinical assessments, right? That half of the patients, in fact, have presumably Parkinsonian tremors, Parkinsonism. And I refuse to believe that they would, in fact, be thinking that the rate of misdiagnosis would be so high. So, of course, that forced a case control study. I always think that the best studies are coming from questions that are elicited at the bedside. And we exactly did that across a number of centers. We compared people who have Parkinson's and a complication, whatever they were, that was functional, well-established, clinically definite, and compare them to age, gender, and disease duration Parkinson's patients, obviously without functional features. And you see here a variety of different interesting features. There are features that are different. For instance, they have higher levodopa equivalent dose, likely because these people are getting worse, and you're increasing the dose of levodopa as a way of compensating for it. But interesting, they have lower motor severity, but greater healthcare resource utilization, and of course, a higher use of SPECT. These are people that are suspected not to have Parkinson's, and then turn out they do. This is what was most dramatic, though, from that particular case control study. It turned out that the functional symptoms preceded or co-occurred with the onset of Parkinson's in a third of the cases. So that was pretty much a very overwhelming indictment to our way of thinking. We think if it's one thing or the other, right? We think there's a neat separation between functional disorders and organic disorders, and that is bound to ultimately change. In fact, we're already struggling with the idea that since functional disorders are organic in some level, we're now trying to separate them out, functional versus other neurological disorders. And so this is, of course, created a lot of difficulty now in our nosology, is challenging our boundaries, challenging our counseling to patients. Sometimes if we're convinced this is what it is, it doesn't mean that it could evolve into another neurological disorder. So one of the lessons here is that you need to continue assessing for patients with functional disorders any other evidence that would not be incongruent with other movement disorders, and just think that if functional tremor can predate other motor features of Parkinson's, there might be other functional disorders that could be, in fact, manifestations of other neurological disorders, part of the phenotype. So we have to keep in mind that this is going to be evolving. All right, so this is I think the last of the cases that I'm going to present here, and this is this was a challenge. I was called from the psychiatry ward because there was a patient, this woman here, that was hallucinating, was saying things that were inappropriate, and was saying them with a girl-like voice, like a little girl. She was saying things not quite sensical. She also was walking funny, they said. And we want you, Dr. Espay, to come and look at her because we want to make sure that the gait is in fact a psychogenic gait. At the time, we were using psychogenics term. I said, listen, I cannot go there, but I can see this patient in the clinic. And what you just saw here was not any inconsistent or incongruent gait. I couldn't really tell.
All right, and I'm going to summarize the history then. Again, July, you had sudden onset of difficulty with behaviors. You were having movements that were looking like seizures. You were speaking like a little girl and couldn't remember anything and were yelling a lot. None of that is something you remember, but you were brought into the hospital.
I don't even remember any of that.
You were brought into the hospital and things kind of got slowly better, but then you were left with some residual eye movement difficulty, and since then you've gotten better, but then your walking is actually worse now. And the eye movements still bother you to the extent you feel that your eyes continue to bounce around. Is that right?
Yeah. Even just like looking at the camera, it's kind of bouncing, kind of going up and down.
Okay, try to look at the camera and try not to.
Okay, so I'm stopping the sound because you heard the story, and this was obviously not ascertained at the time of the early evaluation. It is now 2 weeks after the hospital admission that I'm seeing her, so this is a little bit later. And what you see, something we rarely see. There is nystagmus, but it isn't downbeat nystagmus, which is typically, when it's very non-specific. Obviously, we think of craniocervical junction abnormalities for downbeat nystagmus. But for upbeat nystagmus, the differential is much smaller. You see there, it's present in primary gaze. It continues to be in lateral gaze. By the way, this was associated with oscillopsia, but the fact that she was saying things are moving was considered to be part of the psychopathology. So in the context of somebody with psychiatric features, some hallucinations, some gait impairment, we would call that ataxia probably in this case, it's fine to say so, and oculomotor abnormalities, especially upbeat nystagmus. What did we miss? We missed this, which of course I'm sure that some of you, and by the way, I then ordered this to determine the extent to which it was in fact present. So we missed diamond deficiency, Wernicke encephalopathy. Now, I have to tell you that this story is not entirely the full story, I don't think, and I will never know the full story. She essentially said she had been vomiting and vomiting and vomiting because she confessed to an affair to her husband. Well, eventually, later on, we learned that there is a possibility that she had been poisoned. And if so, there is a juncture between Wernicke encephalopathy and arsenic poisoning. And in fact, you can have in both conditions upbeat nystagmus. So when you look at the list of disorders that are associated with upbeat nystagmus, the two on the list are arsenic poisoning and Wernicke encephalopathy. So it's a very short list. It's a very interesting case. So I don't know if this was a combination of the two. We thought it was thiamine deficiency. Clearly, we gave him that thiamine. She got better, but nowhere back to normal. So The oscillopsia went away because the nystagmus, the oculomotor abnormalities responded, but the gait only mildly improved. So she remained a little bit impaired. And it could have been that this is a case where you have both the two conditions. So the lessons here after establishing a diagnosis of FMD is do not delay consultations. Well, even before in this case, just go. If you're called from the psychiatry ward, I think it's important to obey that very quickly. Upbeat nystagmus, narrow differential, thiamine deficiency, and arsenic poisoning. And this is the reason why perhaps there is the two of them are combined. It turns out that they act on the same pathway, the glycolytic pathway. So this was a very important case for me. This is the summary of the key lessons that I selected for this session that I hope all of them will now be emblazoned in your mesial temporal lobes and be brought back to the fore, that as they have haunted me, to remind me of the kinds of things to be watchful for, that I hope that this was helpful to you as well. This list, obviously, I won't read for you, but I've made the case with each of those, how important it is that you rethink every patient. And in that, I continue to do the exercise with our fellows to keep on thinking about each of the cases we've seen every time we see them, because we can be wrong. We're fallible, and we want to make sure that if we're going to be fallible, that the mistakes we're making are new ones, not the same ones time and again, if we don't recognize what those are. And with that, I want to thank you again, from Cincinnati to India and to everywhere in the world that is connected to this particular session. And at this point, I hope I've left a few minutes for discussion, any questions and any comments. So thank you, everyone. I'm going to end the sharing so that we can see each other.
Thank you, Dr. Espay. It was a wonderful session as always. I think you are now going to become very popular in India. And,
well, I would love it. But India is popular in me already, so it'll be then reciprocal.
There are, I think, very few people who are, I think, so humble as to acknowledge all their mistakes. And I think we all learn from mistakes. So that's a great thing to come out with that. There are lots of questions. So maybe Dr. Wali, you could start off with some of the questions and we can carry on.
This from Shashank Jaiswal. Sir, would it be possible to upload the saccades and saccadic intrusions somewhere on your YouTube? Would it be helpful? Kindly, thank you.
Not sure if I captured that. Let's see if I may read it. Is that when was that sent? So I can perhaps read it from my end. I see a list of. Oh yes, okay. Would it be possible to upload the saccades and saccadic nutrition seminar on YouTube? You know what? I think it'll be just fine. I have no problems with that. All of our patients have signed consent form for use of their videos for educational purposes, so that would be perfectly fine.
I have to confess my mistake of today. I forgot to start the recording.
What? Brilliant stuff has been said. That
I started. Somebody reminded me in between, and then I started. So I'm sorry.
No worries here. No worries, but certainly I particularly am not. There's not a problem for me to do that. And in fact, for people that want a copy of the presentation, I can send the PowerPoint slides. No problems. Obviously, you have to be confidential with this. You cannot disseminate too widely, but if it's within a certain perimeter and it's all for education, I have no problem with that.
Great, thank you.
And there is a question by Ashish Anand. Your recommend head size in NPH patients?
It's a great question. So it's not been studied too well, but the idea is that NPA patients often have a large head circumference. My sense is that that is in part because a number of patients we diagnose with MPH by virtue of very large ventricles have congenital hydrocephalus, not true MPH. Now, how would I test that hypothesis? I would test that hypothesis by reviewing those who have the largest head compared to people with normal size heads, but with equal ventricular volume. My sense is that that study cannot be conducted because if I were to adjust for the ventricular size, I would probably be in a situation of finding that most people in the congenital hydrocephalus group would in fact be also clustered among people with the largest volume. My sense is that when we see an adult with really, really large ventricles, we say, oh, it must be MPH. My sense, if you're really impressed by the ventricles and there is no subarachnoid enlargement, like I showed you in a couple of cases, you may want to be thinking twice about those patients. They may in fact have congenital hydrocephalus, and doing a drain for those patients would either do nothing or potentially could in fact harm them.
Thank you, sir. Then there's a question from Jagdish Agdi. Can you please explain the process of 3 days lumbar drainage? When after drainage, LP do you assess the gait and cognition?
Yes, the way, so there are two methods to do this. Large volume tap, which is a removal of 40 to 50 cc's of cerebrospinal fluid, and a 3-day, usually in hospital, lumbar drainage procedure. It's called ELD, external lumbar drainage. A drainage is created from the lumbar region, and the removal is 10 cc's per hour over 3 days. The thought is that that in fact allows us to better get a glimpse of what the behavior may be like with a shunt. So it really replicates a shunt function to a great extent. We typically assess those patients after they complete the 3 days assessment. We end in the morning of the 3rd day and assess them in the early afternoon of that same day. With the large volume tap, which I must admit we're doing more of those than we're doing lumbar drainage anymore, given the logistical complexities of bringing patients to the hospital. With the large volume tap, we do the gait and cognitive assessments 1 hour, within an hour really, of the drainage of the CSF. This literature of MPH is really plagued by a lot of open label studies. So, and in fact, one major deficiency is that truly sham controlled randomized clinical trials have never been done. So we are acting on a procedure, in this case, a very much invasive procedure, the shunt placement, on the basis of open label anecdotal experience, a lot of class 3 and class 4 studies.
Alberto, no,
Yeah.
about this CSF removal, there is always a problem. I mean, when you have sort of, I look upon it as doing a high volume lumbar drainage is the least you can do. If you get a positive response to that, then you are definitely going to get a response to shunting, but you might miss quite a few. There will be false negatives here. If you do continuous lumbar drainage, you catch more. And there might be some people like the one you showed where lumbar drainage didn't show and yet he responded to shunting.
Yeah.
But you can't go and do shunt for everybody. So
very good point. Very good point. It's a difficult situation. And in reality, why should we make a diagnosis of a condition on the basis of response to therapy? That's the other element to this discussion. We diagnose MPH if patients respond to a test that is imperfect. So that's something that we have to take into account.
Sometimes what I do is if a person shows a response to lumbar drainage, I send them home with Diamox. If they remain all right, well and good. If they worsen, I call them back again, do a lumbar, and if he responds again, then I say, okay, now you are definitely.
Interesting. That is an interesting approach. So you do the large volume tap.
Let him worsen again after stopping. So he goes back and they say, okay, he had improved. His gait had improved, he had become continent, and he went home again, became incontinent, and he would repeat again. Now probably it is because doing lumbar drainage, the problem is infection. So we are not worried about infection when you put in a drain.
Yeah, no, I That's a great, fascinating. I like that approach because if you can make a decision at least over 2 or even 3 sessions rather than one may have also a placebo effect. That's the other thing, right? And there's one study shown
usually these are elderly patients, they are demented, so the family needs time to decide. So they also see, yes, he improved, again he worsened, yes, he's improved, so then they are willing to go for the shunt.
Well, I think I would completely agree with Sudhir in this. In some cases that does happen like that, where it's not so clear, and even if there's can you hear me, Sudhir?
Yeah.
Even if there is a response, the relatives are sometimes very apprehensive about whether the shunt process is going to make a difference. So there are a couple of questions I had. One is the approach which Sudhir uses when the people are not very clear and when our response to large volume tapping is not very clear. That's when this approach works. We call them again. The other aspect was that when you say large volume, usually what we are doing is draining 30 ml. So is that what you do for large ml or large volume or something different?
I consider that insufficient. So I suppose that if you have response from a 30 cc drainage, that in a sense means you've made it less likely, and therefore you're going to capture, certainly the people you're going to capture may be overrepresented in the people that will respond long term, but then you're going to miss a number of people that could have responded, but you didn't select for shunting because you limited the sensitivity by reducing the amount of volume extracted from the CSF.
So what as Sudhir mentioned, we are always worried about infection. That's why this what we are doing standardly all over is doing 30 ml day 1, day 2, and day 3.
After listening to Alberto's talk, I have been starting removing 40 to 50 ml now. In Indians, we remove 40. So that the
yes,
weight.
I think 40 is better. 40 is definitely better. Yes.
The other point was that does the first MRI showing the CSF flow across the aqueduct make any sense? Does it help you?
It is one element that I take into account. I like to see it. When I don't see it, I worry. But when I see it, I don't think it by itself is good enough. What I'd like to see is subarachnoid space enlargement of the so-called DASH criteria, the disproportionate enlarged subarachnoid space hydrocephalus. The ones that to me make the most sense is the redistribution of the spinal fluid into the subarachnoid spaces. So if you see only ventricular enlargement and even high volume or high flow in the third ventricle, but zero enlargement of subarachnoid spaces, my sense is that those are going to be patients that might respond, but they will not be represented among those who go on to have sustained response. And in fact, I think that there is a little bit of a hint in our end that most often people who are in the persistent response group have a lot more of that. Although this is all now at this point anecdotal, I don't think this is being yet carefully studied.
The proof of the pudding is in the lumbar puncture, no? I mean, even if the radiologist says, I'm seeing the flow and I'm seeing this sign and you see the angle, but if he doesn't show response to CSF drainage, I would be wary.
Yeah, exactly. Absolutely. I also think so. If there is no response, now I show you a case where of course there was no response and I was wrong. So that is going to be a flawed decision as well. In some people, presumably we're excluding not that many people in that way, but we may be excluding a few, and so that's important. By the way, that I spent 3 hours with that patient when he came back. Finally, he accepted, and I reviewed the procedure and what was on. And one of the things that happened is that this man actually didn't have 40 cc's. He had like 32 cc's removed. So yeah, so that was another. I learned tremendously from him. I made too much of the story in the cognitive onset this episode of hallucinations. I think I just built it into that. And then once the CSF profile, so he didn't respond to shunting, to large volume tap, and an abnormal CSF profile for Alzheimer's, right? So I figured out altogether it could not be. So it was just a great learning case.
Alberto, what do you value more? The increase in the velocity of gait or the tug test? How many seconds he's taking to walk a particular distance? Because that is easier. What we do in our places, we do a tug test, time get up and go test, and see how many seconds the patient is taking before the lumbar puncture and after the lumbar puncture.
Yeah. I think velocity is, velocity in any of those, in either of those metrics will work just fine. We do gait parameters obtained with an electronic mat, the Zeno walkway, and it's a good one, but many of the parameters that are there are not necessarily that important as the actual velocity. If you have increase in stride length or reduction of step width or any of these, so I don't think they're as predictive as gait velocity.
You see how many seconds he's taking to walk the same distance. Which
I think that's exactly, yeah, that's the most sensitive in my mind.
So would you say that if you have somebody with a good classical triad and who has dash and who has tight cortex, at the top he is tight, so would that be a good person like that, even if after the lumbar puncture, you don't find much improvement, would you still go ahead and have a shunt?
I must admit, that's one of my elements of evolutions. I started by showing you a case, it was vascular Parkinsonism, and I know what the difference between vascular Parkinsonism and normal pressure hydrocephalus. And if I think there is one difference between the way I thought then, when I knew what those conditions were then, now I don't. I really don't know where one begins, the other end. I don't know really. So I now have even a lower threshold for doubting the results of a negative test, especially if I have evidence, as you're pointing out on imaging, that would tell me that there is a potential for true MPH, meaning hydrocephalus plus subarachnoid space enlargement. So that to me, I would still consider. I probably like the idea that Sudhir was pointing out. Maybe in that case, if it was negative, I would repeat it and maybe make a decision after 2 or 3 lumbar punctures, which in fact used to be the case before we did lumbar drainage. And lumbar drainage became a more standard way and perhaps a more sensitive way of eliciting individuals that were going to respond to shunting. The recommendation used to be you just do more than, do 3. If the first is negative, the second is negative, go to a third. If the third is negative, then you know that couldn't be, and then you move on to other elements of the diagnostic workup and treatment. So I now have a very low threshold for this. This reminds me of an ethical issue, which I recognize all of us deal with. Let's imagine that you have the overall confines of MPH. We think it's MPH, but you also think the brain is not normal. You think this is an individual that likely is harboring Alzheimer's, dementia with Lewy bodies, or progressive supranuclear palsy, the 3 neurodegenerative conditions that may most likely present with an MPH-like phenotype. Let's say that you do still a large volume tap and there's improvement, and you decide to go for the shunting. I think that if there is a response for, let's say, 6 months, and then the deterioration resumes or people worsen, who are we to say, but that we shouldn't have had it because that person really was on his or her way to developing something else? Who are we to say that 6 months were not going to be worth the, I don't know. So I'm even less convinced that I know even the answer to that question. I think that I now know a lot less about some of these patients. And so therefore I have a low threshold for initiating a therapy that has the potential to be superior to any of the medical therapies that we have for patients with cognitive and gait difficulties.
The scary part in your first case was the MRI, even the ischemic lesions sort of, the into bracket ischemic lesions, they were away from the ventricles. And so normally one would think normal pressure hydrocephalus, the periventricular lesions should be next to the ventricle, but they were away also.
Exactly. That's a great point. Yeah. So there was some deep ventricular spotty white matter, and this man had vascular risk factors. He must have had a small vessel ischemic disease, but I think we jumped to conclusions very quickly. And if you look at the literature that got us convinced that increased signal on T2 and flare imply microangiopathic disease, there's very literature. So it's only 2 studies. Virtually one is very, very small. The other one is a cadaveric study. So we don't have good imaging pathologic correlations of increased signal on periventricular and deep white matter. We just imagine vascular situations is too common. If you see it, it must be, if you see an imaging increased signal, must be vascular. But my sense is now that we're more mindful of the complexity of each of these patients, a number of them have genetic leukoencephalopathies too, that we have to keep in mind. There are 2 genes that are now considered common among the group of conditions that are referred to as vascular, they have a vascular pattern. One is COL4A1 and the other one is CSF1R. CSF1R is what also has been in the past referred to as axonal leukodystrophy. So these are patients that before we do those genetic analysis were thought to be vascular. They have vascular dementia or vascular Parkinsonism. And little by little, we're kind of teasing away at the etiologies that are non-vascular of these pseudo-vascular, pseudo-Parkinsonian, often the case individuals.
Dr. Wali, you want to take the last couple of questions? I think we have.
Yeah, because quite a few of the others one have been already discussed through your present discussions. I will. By Sunny, I suppose, should CJD be considered as a differential diagnosis of RPD if patient had not survived beyond 1 year?
If a patient doesn't survive for more than a year, what?
The patient of yours who looked like a rapidly progressive PSP, would you think of CJD? I had thought of
yes.
CJD.
Yes, I would in all of these patients for sure. I would be thinking about that. In that particular case, however, the oculomotor abnormalities were so profound, and I'm not aware of any CJD case in which you find any degree of oculomotor impairment, at least of that kind for sure. But certainly, yes, I would definitely keep that in the differential.
Yeah. And there's a question on PSP versus DLB case. Role of MRPI as a radiological clue in such scenario.
Let's see, can you read it again?
The question is for PSP versus DLB. Role of MRP as a radiological clue in such scenario.
Oh, okay. Yes. No, that's a very good. Well, so this particular case that I presented, DLB, has so the particular radiological clue being asked here, the MRPI, is essentially a ratio between the third ventricular width and the lateral ventricles, the anterior horns of the lateral ventricles in the greatest dimension. And if it's beyond a certain limit, it implies that you may be dealing with PSP. Usually is the Parkinsonian phenotype of PSP, the PD-like phenotype. Well, as you saw here, in that case with dementia Lewy body pathology proving is that large third ventricle, I think would have met criteria. Essentially, it implies that you have a large third ventricle and a reasonably sized lateral anterior horns of the lateral ventricle. Which was the case in that situation. I typically like that though, and I'm always mindful that if you have a patient with a large third ventricle, to think about PSP. I think it's very important. If you have a patient with Parkinson's, you think it's Parkinson's disease, but atypical features, particularly if it there is either a partial response to levodopa, or the response begins to be eroded because on a dose-dependent fashion there is freezing of gait. If the MRI has a large third ventricle meeting the MRPI index, I would suggest to think of a tauopathy, and this would be more PSP than truly DLB. DLB is not been, I don't think, characterized as much in terms of this particular radiological clue.
Then there is a question from Dr. Mittal. For patient with 4G, freezing of gait, and MRI suggestion of NPH, would you like to consider L-DOPA trial or LP first?
L-DOPA for sure. Anybody with any gait abnormality within the broad spectrum of what we consider potentially Parkinsonian, levodopa certainly would be an easier thing to do. It would not be, it's interesting. We've all probably seen patients with a shunt that now we're treating with levodopa. I myself have a number of patients like that for levodopa to begin with, but we have patients on shunt with levodopa because now we recognize there is some degree of levodopa responsive Parkinsonism. So have a low threshold to using levodopa in any of the patients with any degree of gait impairment first, ahead of considering a trial of large volume tau.
Okay,
And,
we should.
Yeah.
You want to
And
take
there is one more question, last question I'll put. In myoclonus patient, how to differentiate it from polymini myoclonus?
Yeah, so polymini myoclonus is essentially myoclonus. It's called polymini, and I'm not sure I like it very much, but only because it's very subtle. It's not a myoclonus that's very overt, but it's a cortical myoclonus, meaning it's affecting the hands and to a lower extent the face. If you have that distribution, it is a myoclonic disorder. So myoclonus is a central movement disorder. It's the briefest of all movements, short onset, short offset. Myokymia looks like jerks, but they are too slow to be myoclonic at all. They also, you cannot tell when one begins and the other one ends, and that's why it gives rise to this undulating pattern. When it is outside of the fingers, you saw an example of an involvement of the forearm. When it's on the forearm, then you see it's kind of an undulating so-called bag of worms manifestation. That, when affecting the fingers, will give rise to something of the type of what you saw. And so very, really different, distinguishable from myoclonus. Particularly this particular saddle type of myoclonus.
I've got a good question from Dr. Agrawal, if I can ask that. Functional overlay on real PD, tremor was it? He says that if only pure finger tremor is present, not wrist or hand, it is always organic, as this is not seen in function. Please comment. I think so. I think that's a fair assessment by Pankaj. I think that yes, if you only see the tremor, I must admit I've never seen that in the context of functional tremor. So that's a good clinical pearl. Thank you, Pankaj. Okay, Alberto, thank you. I think the final thing we should say is that I've seen Dr. Singhal, my teacher. He had given a talk on mistakes. I mean, lessons he has learned from mistakes. So usually it is people who are very senior who go back and give this talk of what I've learned from your mistakes. So you have started early, or you have become senior very early. The other thing is Stephen Covey and many other people have said that make mistakes every day because you learn from it, but don't repeat the same mistake again ever in life. But keep mistakes because that means you keep learning. Absolutely. So with that, I think we'll tell everybody that don't worry about making mistakes. If you don't make a mistake, you're not trying anything new. You're not learning. Exactly. And thank you. We await for your next talk. Thank you, Sudhir. On the 12th of June. Thank you. Look forward to it already. Thank you and good night. Thank you so much. Thanks, everyone.
Thank you.
Thank you. Thank you so much.